Okay, let's unpack this. Welcome to the Deep Dive, where we pull fascinating insights straight from the source material. Today, we're tackling a topic that, well, it touches on health, sunlight, and maybe a few surprises. Vitamin D levels in children.
That sounds great.
Our guide for this deep dive is a specific piece of research. It's a recent Ph.D. thesis out of Turkey focused on kids aged 0 to 18, mainly using data from Ankara. We've got excerpts and a briefing document that summarizes the key stuff.
Right. And our mission here is to really look past the headlines, dig into what this specific study is telling us. Things like, how common is vitamin D deficiency in this age group, according to this data? Who seems to be most at risk? And what's the real-world picture for prevention and treatment? What does this research actually show on the ground?
Sounds good. So let's start with the basics, just like the source does. What exactly is vitamin D? Maybe a quick refresher?
Sure. Think of it as a fat-soluble vitamin, but it's got this unique twist. You can get some from food, yeah, but our bodies are actually designed to make most of it.
Right, in the skin.
Exactly. In the skin, when it gets hit by a specific type of sunlight, the UVB rays.
So it's not just about chugging fortified milk then. Our skin's doing a lot of the heavy lifting, assuming the sun's out.
Precisely. But that vitamin D, whether you make it or eat it, isn't ready to go immediately. It needs to take a trip. First stop, the liver, then onto the kidneys. That's where it gets converted into the active form the body can actually use.
Okay, and why is this whole process so important? What's the big deal about vitamin D?
Well, the source really highlights its main job. Managing calcium levels and building strong bones. Rickets, that bone-softening condition in kids.
Yeah, the classic deficiency sign.
That's the classic example of severe deficiency. But importantly, the source also needs its effects go beyond just the skeleton. It seems to affect the immune system, too, among other things. That's a big area of research right now.
Got it. So when this study talks about kids having low vitamin D, what numbers are they actually using? Like what's deficient versus insufficient or normal?
Good question. They're using definitions that line up with the Turkish Ministry of Health and international consensus. So deficiency is defined as having serum 25-OHD3 levels below 12 nanograms per milliliter.
12. Wow, that sounds quite low.
It is pretty low. Then you have insufficiency, which is the range between 12 and 20 ngml.
Okay.
And normal, or what they call adequate, is considered anything over 20 ngml.
Right. So 20 is the magic number for being in the normal range. And this 25-OHD3, that's the main thing they measure.
Correct. The source confirms that 25-OHD3 level is the best way to check someone's overall vitamin D status. It reflects both sun exposure and what you're getting from diet or supplements. And yeah, that's what they measured.
Perfect. So we know what vitamin D is, why it matters, and how they measured it. Let's set the scene for this specific study. Where did this happen? How'd they get the information?
So this was a retrospective analysis. That means they looked back at existing data.
Okay, looking back at records.
Yes, specifically electronic health records from a third-level pediatric hospital in Ankara, Turkey. And the data covered the year 2017.
Looking at existing records like that,
yeah,
it can give you a really powerful snapshot of what's actually happening, right?
Yeah.
How many kids were involved? Was it a big group?
It was pretty substantial, yeah. They analyzed vitamin D levels for over 3,300 healthy children, 3,068 to be exact. And they also included data from another group, 182 children who were classified as obese. All of them were between 0 and 18 years old.
All right, let's get to it. The big picture findings from this Ankara study. Based on this large group of kids, how common is it for them to have vitamin D levels below that normal 20 ngml mark?
The findings were, they were quite striking, actually, in that big group of healthy kids. The study found 42.9% had levels below 20 ngml.
Wait, hold on. Did you say 42.9%? Almost half of the healthy kids in this study weren't hitting that normal vitamin D level. That feels surprisingly high.
It really does, doesn't it? And if you break that down a bit more, 18.1% were actually in the deficient category, so below 12 ngml. Okay. And another 24.9% were in that insufficient range, between 12 and 20. So insufficiency was actually a bit more common than outright deficiency in the healthy group, but you add them together. It's a huge chunk.
Wow. How did the obese children compare? Was it different for them?
Yes, definitely. As a group, their vitamin D levels were significantly lower. The average level in the obese children was only 15.7 ngml.
Compared to what in the healthy group?
compared to 28.7 ngml in the healthy kids. The abstract and summary docs mention something like 37% up to maybe just over 50% of the obese children had either deficiency or insufficiency. So, yeah, this led the study authors to conclude, based on their data anyway, that vitamin D deficiency is still a really significant public health problem, even among healthy children in that region.
That almost half number for healthy kids?
Yeah.
Yeah, that's definitely going to stick with me. So here's where it gets really interesting, right? If it's that common, who is most likely to have these low levels?
Yeah.
Did the study identify specific risk factors?
They really did drill down on this. And one of the most notable findings, I think, was that adolescent girls were identified as the highest risk group.
Adolescent girls specifically? That's not necessarily the first group I would have guessed. Does the source give any clues why?
You know, the source mostly presents the finding itself, the data point, rather than digging deep into why for that specific group. Maybe lifestyle, clothing, less sun. But it doesn't speculate much. It's just a really key finding, and there's a vulnerability there. Another big factor, maybe less surprising, was the season.
Makes sense.
Deficiency and insufficiency were way more common during spring and winter.
Light sun exposure, obviously.
Exactly. And they actually put numbers on the risk. It was 2.2 times more likely to have low levels in spring compared to autumn,
Wow.
and 1.7 times higher in winter compared to autumn. So autumn and summer were definitely the better seasons for vitamin D levels in this group. Geography also mattered. Ankara, where the study was mainly based, is around the 40th parallel north latitude. The study found that kids living at or above that 40th parallel, they had significantly lower average levels, and they were 2.1 times more likely to be deficient compared to the kids who live south of that line.
Ah, so latitude makes a difference because of the sun angle.
Precisely. The angle of the sun's UVB rays just isn't as effective for making vitamin D in the skin the further you get from the equator, especially outside of the peak summer months. Though the study did mention a limitation here. The sample size for the kids living south of the 40th parallel was pretty small, only 89 kids. So, need to be a bit cautious with that comparison.
Right, okay. And we already touched on obesity.
Yes, obese children were consistently shown to be at higher risk. The source brings up a couple of possible reasons. Maybe the vitamin D gets sort of trapped or sequestered in fat tissue, so less is available in the blood.
Interesting.
Or perhaps lifestyle differences mean less time in the sun. The risk seemed particularly high for kids with a BMI of 30 or more. And of course, the source also reminds us about those general things that affect skin synthesis, you know? Skin color, more melanin acts like a natural sunscreen. Time of day you're outside, how much skin you actually expose. Even things like altitude and air pollution can play a part.
Okay, so we know who's most at risk. What about actually preventing this? The study looked at prophylaxis, right?
Yeah.
Basically giving kids regular vitamin D supplements to stop them getting low in the first place.
Yes, and this part showed a really clear benefit. Healthy children who were reported as getting daily prophylactic vitamin D, well, they had a significantly lower rate of deficiency or insufficiency, only 25.3%.
Okay, hang on. 25% compared to the almost 43% we heard earlier for the overall healthy group. That's a big difference. So prevention works.
It certainly seems to, based on this data. It really highlights the power of just simple daily supplementation. But, and this is a big but, here's the real-world challenge the study uncovered. While using prophylaxis was super high in infants under 1 year old, like almost 100%, probably thanks to public health pushes.
Right. Standard practice for babies.
Exactly. But use just plummeted in older age groups.
Ah, so the youngest kids are getting it, but the habit just isn't sticking as they get older. Is that the idea?
That's exactly what the data suggests. And remember those adolescents, the group we just identified as highest risk?
Yeah.
Only a tiny fraction, about 1.7%, were reported as actually using prophylactic vitamin D.
Wow, 1.7% of the highest risk group. That's not good.
Not ideal, no. The source does mention the Turkish Ministry of Health guidelines. They recommend daily prophylaxis, 400 IUs a day for babies under 1 and 600 IUs a day for kids over 1. That can come from diet or supplements. They also recommend, sensible sun exposure, maybe 10-15 minutes outside around midday, and vitamin D-rich foods.
And for those specific high-risk groups you mentioned, like obese kids or those on certain meds, would the advice be different?
The source suggests that, in clinical practice, higher prophylactic doses might be considered for certain vulnerable groups. Kids with conditions causing malabsorption, maybe those on long-term steroids or certain anticonvulsants, kids with disabilities, obese children, those with darker skin, or those living way up north or at high altitude where sun is less effective. they might need a bit more.
Okay, so prevention is effective, clearly, but getting older kids and teens to actually stick with it seems to be a huge barrier in the real world, based on this study. What about the kids who are diagnosed with deficiency and actually start treatment? How well does that work out?
This was another area where the findings were, well, pretty concerning. The study found a really significant challenge with follow-up care. So you have these kids who were already diagnosed with vitamin D deficiency, and they were started on a treatment plan, but only about 30% of them actually came back to the clinic for their scheduled checkups, their control evaluations.
Only 3 out of 10 came back for a follow-up. Seriously?
Yeah, that's what this data showed. And probably linked directly to this poor follow-up, the study concluded that in many of these real-world cases, the vitamin D treatment often resulted in failure. It just didn't work. And the study authors really stressed that this lack of follow-up is critical. Why? Because those check-ins are essential, right?
To see if it's working.
Exactly. To check if the child is actually taking the medication, if they're taking it correctly, if the dose is right for them. Without that feedback loop, things like adherence problems or dosage errors are the likely culprits for why the treatment failed so often.
That makes sense.
Yeah.
And let me guess, which group was least likely to come back for follow-up?
You probably guessed it, adolescents again. The same group with the lowest prophylaxis use and the highest risk of deficiency in the first place. It's a concerning pattern. Now, the source does briefly touch on typical treatment approaches. For nutritional rickets, it mentions higher daily doses, often way more than the prevention doses, like maybe 3,000 to 6,000 IU daily for younger kids, or 6,000 IU daily for adolescents, sometimes with calcium too.
Okay.
It also mentions something called Stoss therapy.
Stoss therapy.
Yeah, basically giving a very high dose over a short period. It's sometimes used as an alternative, maybe for older kids, say over 3 months, who might struggle with taking something every single day. For example, the source mentions maybe a single dose of 150,000 IU for an adolescent, or maybe a weekly high dose for several weeks. But the study really emphasizes that it's the total amount of vitamin D they get over time that matters for treatment success. And crucially, that follow-up is needed not just to check adherence, but also to monitor for potential side effects, like getting too much calcium, especially with those higher treatment doses.
It sounds like the study provided a really clear, if maybe worrying, picture. But did they mention any limitations? Things we should keep in mind about the research itself?
Yeah, they were upfront about several points. Like we said, it was retrospective, using existing health records. That kind of data can sometimes be incomplete or maybe not perfectly consistent.
Right.
And the limited follow-up data we just talked about, that was definitely a major limitation. It makes it hard to say definitively why treatment failed in many cases. The study also didn't collect individual lifestyle details. Things like, how much time did this specific child actually spend in the sun? What clothes were they wearing? What exactly was their diet like? All those things can impact vitamin D levels.
Sure, you wouldn't necessarily have that in standard health records.
Exactly. And finally, it was a single-center study, mostly data from one hospital in Ankara. So the findings might not perfectly represent the situation across all of Turkey or necessarily in other countries with different latitudes, lifestyles, or public health programs.
Okay, so pulling all of this together then, what's the main message? What's the key takeaway for us from this particular deep dive?
I think the big picture is that vitamin D deficiency and insufficiency are, remarkably common in children, even the healthy ones, at least in regions like Ankara, based on this data. It's definitely not just some rare issue. And certain factors clearly increase that risk. Being a teenager, especially girl, the time of year where you live geographically, and body weight.
Okay, so it's common and there are clear risk factors.
Right, and we also saw that prevention, using daily supplements, is effective according to this study. But, and it's a big but, getting older kids, particularly teens, to actually take them consistently seems to be a major real-world hurdle. And then, compounding that problem, if a child is diagnosed and treatment starts, the study shows there's this huge gap in follow-up care, which appears to be a primary reason why treatment often doesn't succeed in practice.
So it really highlights that it's not enough just to know what to do or even to start the process. The real challenge is in the follow-through, both for prevention and treatment.
Precisely. This study really puts a spotlight on that gap between our clinical knowledge and what actually happens in the real world, And understanding these findings, I think it's important for everyone. It might make you think about vitamin D status for yourself or your family or kids and it just reinforces how vital consistent prevention and, importantly, follow-up really are. They're not just optional extras.
So this deep dive into the Ankara study has really painted a clear picture, hasn't it? Vitamin D levels are low in a lot of children, especially in those vulnerable groups like adolescents, even though we have ways to prevent it that work.
It certainly shows that, yeah. Prophylaxis works, but the uptake in older kids is poor. And the follow-up for those diagnosed, that's a significant weak point, at least according to this data.
It kind of leaves us with a big question, doesn't it? If prevention is so effective, but we're seeing these huge gaps in actually using it consistently and in following up on treatment, especially in the highest risk groups like teens, what could actually be done differently, systemically, practically, to make sure this vital nutrient doesn't just remain a silent health issue for so many young people? It really highlights a critical challenge, I think, in how we translate what we know in medicine into sustained effective action in the real world. Something to think about. Keep exploring.